Will you introduce me or shall I start?
Hello, everyone. My name is
Do I
Natalia.
wait for you to introduce me or do I
Yes,
start?
yes, we will start right now. So, hello, everyone. My name is Natalia Saukova, and I'm an International Scientific Officer of International Association of Dental Students. We have an honor and pleasure to welcome Dr. Nikos Mattheos today with us in IADS webinar, who is a Clinical Associate Professor and Associate Dean at Faculty of Dentistry in the University of Hong Kong. Welcome, Doctor.
Thank you very much, Natalia. Good morning, good afternoon, good evening, dear friends and dear colleagues, and thank you for joining this webinar. I bring you a lot of greetings from your friends in Hong Kong, and I would like to take the opportunity to introduce myself a little bit different. And today I would like to introduce myself as an old IADS veteran as well. And for me, it all started around 1991. Back at that time, I was a very enthusiastic young dental student, and I had the blessing to attend the first international student congress in Amsterdam of the ADSA. And I think that was such an experience that opened so many different opportunities in my life, changed my mind forever. And ever since, I have been moving on, attending and following and contributing and learning from all my friends and colleagues in the different associations, the ADS, the IADS, later on the EDSA, and lately the young dentists worldwide. We might be not young at age anymore, but definitely young at heart, and it is a great opportunity for us to keep our connection with the motivation, the enthusiasm, and all the innovation that comes from the student associations, from IADS, EDSA, APDSA, now that I'm in Asia Pacific. So I'm very honored to be here today. Now, to let you know a little bit about my current background, I am an associate professor and director of the implant dentistry clinic in the University of Hong Kong. We have two different postgraduate programs, one part-time 2 years in implant dentistry and one 3 years full-time. And of course, I'm also active with patient care and research. Also, since 5 years, since I arrived here, I have acquired my second identity as well. So for those who speak Chinese among you, you can also read my new name, which is Ma, and means horse in Chinese. It sounds much better in Chinese than it sounds in English. So our clinic, the implant dentistry clinic of the Faculty of Dentistry, is a multidisciplinary clinic. We do not treat implant dentistry as a new specialization. We do not educate implantologists. On the contrary, we see implant dentistry as a very, very useful tool, as a handy modality in the hands of the rehabilitative comprehensive care. So we combine the input from the different disciplines, from periodontology, from oral surgery and prosthodontics, and we try to comprehensively educate the dentist to implement dental implants in the comprehensive treatment plan exactly where it should belong. Now, I will start my thoughts today with something that occurred to me a few months ago when we were preparing for our massive open online course. As you might know, some months ago, we initiated the first MOOC in implant dentistry. MOOC is a massive open online course where everyone can attend for free through an online platform that relies right now in the United States. So as we were preparing for this course, I was receiving literally dozens of emails and messages every day from potential candidates and people who were interested. And many of them were with different thoughts and comments. Many were asking questions. Do you know what was the most common question that we received before our course started? It was actually many people who were asking me, will I learn to place implants at your course? Now, this is a very interesting question. Not only because we were dealing with an online course. Of course, in an online course, we will not be teaching clinical skills. But the question itself points to the direction that many people perceive implant dentistry as placement of dental implants. Many people really misled to believe that if you know how to place an implant, that's all you really need to know about implant dentistry. But in reality, the truth is very, very different. And this is something that I would like to get the opportunity and make the point today. Just to give you an idea of how far we've come with implant dentistry in the last few decades, I have some small photo to share with you. You can look at this person in the screen, which is almost dressed like an astronaut, and he has a closed breathing circuit. Even the air that she breathes is not really left out in the room. Now, you might wonder where this picture comes from. It actually comes from one of the very first textbooks created for implant dentistry in the late 70s by Professor Bronnemark. And the person you just saw before is a dentist in his clinic who is about to place a dental implant. Now, if you compare the situation in the 70s with what happens today, where we can have dental implants placed safely and predictably in almost any given well-organized outpatient clinic, we can realize that we have made a tremendous progress in implant dentistry. Nevertheless, although our demands have increased and so our success rates, we still face significant challenges and we see an increasing number of complications. Now, the complications are really depending on many different factors. And I think if I flip it around, the factors that will contribute to a successful treatment are also coming from many directions. We need, of course, the operator, who should be educated, competent, and well updated on the evidence basis of the treatment that he is carrying out. Then again, we have the patient selection, the proper patient, and then also the patient motivation and engagement with this treatment. Then a key element is the proper treatment plan, the proper identification of the problems, and a proper sequence of the solutions. And then, of course, we have the procedures and the devices that we have to use for our treatment. And all this together will actually contribute to success. And this is why today, one of the greatest problems we face in implant dentistry is that people, instead of seeing the whole picture, the dentist, the patient, the treatment plan, they focus too much on the procedures. Many believe that mastering the procedure will be enough to master a successful treatment. But in reality, the education we need is much, much farther. And to start the discussion about how do we envision today our treatment philosophy and our treatment planning, I would quote one of my teachers, Professor Lang, who used to say, whenever you see a patient, you should keep the end in mind. That means you should always envision what is the end point of your treatment. And there must be an end point in your treatment. We should be able to define this end point. How do we want our patient to be at the end of the treatment? And then this end point is going to guide all your actions and all your treatment planning sequences. So we should begin by actually having the end in mind. In our case, that means that when we look at the patient at the first appointment, we have to realize how do we want the patient's dentition to look like when the treatment is finished and when the patient is leaving the office. So we need somehow to see the initial picture and after a certain sequencing of thought and procedures to actually visualize how the patient will be with the final treatment being conducted. Now, how do we do this? We need some guidance, we need some rules, we need some principles, and we need some sequence that we have to follow in each and every case. And the principle is what drives all your actions. One of the major things that we see around us when it happens to commercial companies, you see they all have a mission statement. What is a mission statement? A mission statement is some principle that supposedly the company is going to follow in order to achieve its goals. For example, Amazon, their mission statement is to be the world's most customer-centric company. Other companies, like Ford, a little bit more complicated. They're passionately committed to providing personal mobility. Disney, they create happiness. And some might be much simpler than that. Have you ever wondered, you as an operator, as a dentist, as a clinician, and also as a care provider, what is your mission statement? What is the principle that you promise to deliver to your patients in order to have a successful treatment? Think about it, because it will be a very important parameter for your future career. I can share with you our mission statement in our clinic, which is to establish and satisfy the patient's needs for aesthetics and function under healthy and sustainable conditions. So this gives you already some of the principles that will guide our treatment plan. First of all, health. We need to establish health. Second, we also need to achieve aesthetics and function, but under sustainable conditions. That means that this, what we achieve today, has to stay with the patient for a long time. And last but not least, we want to address the patient's needs. So we want to achieve patient satisfaction. Now, how does this transfer and how do we visualize the end? It all falls with our treatment planning sequence. First of all, we have the patient assessment and the diagnosis, prognosis, and treatment planning. So this is the time when we have to understand the patient's background and to understand the patient's needs. And the patient's needs sometimes might be different than what the medical background will imply or than what our knowledge tells us. So this is the first step, and this is the very critical step where we understand the patient's needs and we see what the patient wants to be satisfied. If we can do it, we proceed, and we agree with the patient on the treatment plan. If not, we have to realistically explain to the patient what is achievable and what is not. Then comes the treatment, and the treatment starts with the systemic phase. This is the phase where we address any kind of general medical problems or any kind of behavioral problems like smoking, for example. The second phase is almost the most important because this is the phase where we treat disease, eliminate pathology, and establish health. So this is the phase where we will treat the periodontal conditions. This is the phase where we will have to do any periapical pathology, root canal treatments, treat caries and its consequences. And then we have to conduct a review and find out that all pathology is eliminated. So if we're free of periodontal disease, free of caries, and free of any other pathology, it is only then we move on to the next phase, which we call corrective or rehabilitation. And this is where we actually rehabilitate the function and restore the aesthetics. And this is the phase where the implants will come, not earlier than that. So you see, there are many steps before we actually get to the point to even discuss or plan about placing a dental implant, and many steps before. And once we have completed this rehabilitation phase, then starts the maintenance phase, which covers the rest of the patient's life. And this is the final goal that we have, which is to be sustainable. Whatever we have achieved, to maintain it for the rest of the patient's time. And of course, the end is guiding us all the way, not only in our treatment philosophy, but even when we plan the procedures, the devices that we are going to use in the specific placement of dental implants. I will give you a small example that we can have from anterior maxilla. To the right, you can see a cone beam CT of an anterior central incisor. It is lying in the alveolar ridge. We all know that once we lose teeth, we're also losing supporting structures. We're losing bone, and we have a consequently different anatomic structure to work with. So in this case, this is where the implant dentistry will be a convenient rehabilitation modality by placing an implant in the correct prosthetic position. And then in some cases, we might need to actually augment the tissues and build back the bone so that the implant can be supported where it should be and not where the bone is. So every time you're facing the situation of missing tooth and you have come all the way to the steps up to the moment that you're placing or you're planning to place your implant, you have to start again from the end. And what we see ahead of us is two missing lateral incisors, but in reality what we need to see is two teeth and how they will look like, what will be their position, and how we're going to restore them with implants. So we start by the end, and we start from the crown that we want to restore. We start with a wax-up, and this wax-up will represent the ideal looks and function of the missing teeth. Now, once we have them on the model, then we'll try to transfer this position on the tissues so that we can understand if our implant can be supporting this position or not. And this is where we can go for a diagnostic examination, radiographic examination, which today the standard would be a cone-beam CT. So you can see in this position, we create a radiographic splint. What you see in the middle is a radio-opaque imitation of the ideal crown. We place it in the mouth while the patient is receiving the cone-beam CT, and then we can see not only the bone and the soft tissues around it, but we can also see the ideal crown and how it relates to the bone we have, so that we can try to plan our surgery accordingly. Cone-beam CT today has reached a very, very high definition and resolution margin. So sometimes if you use the right resolution and if you retract the lips, as you can see in the pictures here, you can not only see the bone, but you can actually see the soft tissues surrounding the alveolar ridge. So at this point, the specific planning phase starts, where we have to evaluate the height of the bone, the width of the bone, and also the anatomical structures neighboring to the bone, and we can plan our surgery. And I don't plan to go into the details of planning the surgery today, but I would like to show you the sequence of starting actually from the end, from the tooth, and moving backwards to planning your implant. Today, our position of the implant will be guided purely by the position of the crown that we want to achieve. So we start by visualizing the crown, and we identify the margin of the crown, which should be corresponding to the margins of the neighboring teeth. And then from this point onwards, we have to count some millimeters, which will be dedicated to the attachment of the soft tissues, and then place the implant just below that line. It is very critical to allow for at least 3 millimeters of soft tissue attachment when we're placing an implant like that of a bone level, because this will be the critical soft tissue biological width that will be established around our implant. And of course, we also want to achieve some symmetric results on the buccal side as well. So ideally, we would like to have another 2 or 3 millimeters on the buccal wall of our implant. Now that would result into a deep placement of implants. And since we're talking a little bit about this soft tissue attachment around implants, I would like to emphasize a little bit how the anatomy around implants and teeth is similar, but also different. What you see now in front of you to the left is the periodontal tissues, while to the right, we have the peri-implant tissues. And as you can see, there is significant differences in the vascularization, in the absence of the periodontal ligament around the implant, but also in the orientation of the connective tissue fibers, which around the tooth are very well structured and very well directed and organized, while around the implant are much less organized. They're actually only around the implant like a rubber band instead of penetrating the cementum as we have in the periodontal condition. Now, starting from the top, we have the sulcus. And the healthy sulcus around teeth is usually between 0.5 millimeter and maybe 1.5 can be also accepted in certain cases. Now, the sulcus around implant, however, is not determined genetically. So we will speak a little bit about it right after. Right below the sulcus, we have the junctional epithelium, and this is the true attachment of the epithelial cells on the surface of the tooth or on the surface of the implant or the implant abutment. And below that comes the zone of the connective tissue, which, like we said, around the tooth is very well structured and vascularized. Around the implant, it's less structured and somewhat compromised in its structural integrity. Now, the sum of the junctional epithelium and the connective tissue zone is what we call traditionally the biological width around teeth. And this is also the case around implants. The sulcus, however, can be very different between teeth and implants, And this is something that I would like to get your attention, because I will get back to this point right after presenting a small sequence of a case. So speaking again on the same sequence that we discussed before, here we have some missing teeth. You can see we have the central incisors missing, and we actually have one lateral which is going to be prepared for a crown on the 1-2 position. So we can define the aesthetic line that we want to achieve, and in this case it is determined by the lateral on the left side. We have to count for the 3 millimeters of soft tissue attachment and then place our implant probably deeper than the bone is in this particular case. Then we will recreate the soft tissue profiles with some temporary crown, and eventually, when the time comes to have our permanent, we will have an aesthetic and pleasing smile. Remember, however, that the mesial and distal side of the teeth is following the scalloping of the mesial and distal tissues. Around implants, however, we have a very flat emergence profile. It's exactly the same mesial and distal as it is buccal and palatal. And that results to a very different probing depth of the sulcus when we're probing around the papilla. So if we want to achieve 3 millimeters of soft tissues from the buccal margin, that means we will have a very deep sulcus around the implant. If you try to clean with the floss the sulcus around the tooth, you see that the floss will not penetrate more than 1, maybe 1.5 millimeter in the sulcus. If we do the same, however, on an implant on the neighboring side, you can see that the floss can actually go 3, 4, 5, sometimes millimeter in the sulcus, because this is exactly an area where there is no functional connection between the peri-implant tissues and the implant itself. So if we want to achieve aesthetic results, we have unfortunately to accept to create a deep sulcus around the implants. Now, the challenge with the deep sulcus is how can we keep the biofilm away? As you can see here, this is a sulcus that is created around an implant, and it's healthy pink epithelialized tissue. The true attachment is only down at the very first millimeters on top of the implant. This is the connective tissue zone and the junctional epithelium. And the rest is pure epithelialized sulcus, where there is no real connection with the abutment or the crown of the implant. Of course, we know that such niche, such a place in the mouth would be very popular with bacteria. But in reality, bacteria will not populate the sulcus as individual species. They will actually migrate there through the biofilm. And the biofilm is actually the main cause of the inflammation, not the individual bacteria themselves on a planktonic state. So what we don't want to happen is biofilm plaque to migrate into the sulcus. And how will plaque migrate? It will always come from the coronal direction. It will form on the very first millimeter in conjunction with the oral environment. So the first couple of millimeters of the sulcus, that will be the danger zone. If we can keep these first millimeters of the sulcus free of plaque through oral hygiene by the patient, then we don't really have anything to worry. If, however, the oral hygiene is defective, or the design of the prosthesis is such that we cannot practice oral hygiene, then biofilm is going to gather, plaque is going to accumulate, and of course, plaque is going to migrate deeper and deeper in the sulcus and create inflammation. So, very often we see reconstructions like this one. In this reconstruction, there might be many problems, but one of the major problems is that actually there is no access to oral hygiene. There is no space left for the patient with a toothbrush or the interdental brushes to clean in between these implants. So no surprise, if you remove this crown, what you will see, this bridge, is significant inflammation all around these implants because of the biofilm, because of plaque. And I even like more the mandibular side of this bridge, because here you can see 3 implants on the right side. You actually see only 1.5, not 3. The first implant is accessible to oral hygiene, is cleanable. The second implant is almost not accessible to oral hygiene. And the third implant is completely buried. You can't really access it as a patient with your brush or any other means. So what do you expect to find if we pull this bridge out? No surprise again, the first implant is in healthy tissues. The second one has a mucositis, an initial inflammation. The third one has already periimplantitis. So every time we see the deep sulcus around implants being inflamed, like in this site, this is a problem that has to be addressed before we actually let the patient continue with implant treatment. Any kind of inflammation has to be addressed with adjusting the emergence profile of the crown and instructing the proper oral hygiene so we can move from the inflamed sulcus to the healthy sulcus. And usually when you see this type of inflamed sulcus, then you expect to see the crown looking like this. You see there's a lot of plaque, there's a lot of even visible biofilm all around this crown. When the crown starts to be clean and free of biofilm and bacteria, this is when the sulcus also starts to be free of inflammation. So again, the design and the positioning of the implant is very critical for the long-term sustainability of the implant therapy. Now, at this stage, once we have completed all these phases up to this point, at this stage starts the most important part, which is the rest of patient's life with the implants. And there, this is the time where we have to conduct a maintenance program. That means and frequent examinations in order to make sure that our treatment and everything we have achieved is going to stay healthy, is going to stay functional, and is going to continue satisfying the patient. And in this maintenance phase, of course, we have to look at different directions every time. And of course, the directions of the patient is very important. We look for any changes in the host, changes in the patient, changes in the behavioral factors, and in the oral hygiene patterns or smoking, if the patient has been a smoker, or the status of the periodontal health, if the patient had a periodontal disease before. Then, of course, we have to assess any changes in the systemic risk and the oral hygiene, pretty much the most important right now parameter for the long-term sustainability of implants. Then the second thing we have to evaluate is the prosthesis. We have to look at the implant crown, the implant bridge, or the different components of the prosthesis to make sure that they're in good condition, that they have a design that allows for access to oral hygiene, and that they are performing without any signs of wear or any signs of problem for the future. Then accessibility to oral hygiene, and finally we inspect, of course, the tissues around the implant, the peri-implant tissues, and that means we have to probe around the implant to see if we have any change in the probing depth, if we have any signs of inflammation, as it can be with bleeding on probing, if we have any change in the soft tissues in terms of color or recession or texture, and of course the bone levels, which are also very important to monitor. If we don't have any change through the probing depth, then probably we don't anticipate any difference in the bone level either. So with that, I hope that I have given you an idea of how we see today the implant treatment, the implant therapy, being a part of a comprehensive care, being a small but very significant component of the total care we give to the patient. And as such, it has its place in the treatment plan, and it has also its philosophy within rehabilitation of the patient. And I think someone who will be a very good practitioner of implant dentistry will first and foremost be a very good dentist. You need to have a comprehensive understanding of all the parameters that actually take place in the mouth before you can design a treatment plan that includes at some point dental implants. And this is one of the reasons why we believe that implant dentistry is not really something that is addressed by a specialization. Of course, you will need specialist knowledge if you're going to do some specific procedures, like some advanced bone augmentations or some really extensive, complicated prosthesis. But on the treatment planning schedule, I think this is where the overview is very important, rather than the isolated and expertise of specific procedures. With that, I would like to conclude our very small introduction to this treatment philosophy today. I would be very happy to have your thoughts, comments, and ideas. You're very welcome to visit us in Hong Kong. We receive every year more than 60 elective student visitors. And in the last 2 years, we have been ranked consecutively #1 in the dental faculties of the world. So this is quite a good time to visit us. We're still #1 and we're very happy about it. Maybe next year when the new ranking comes, if you're #1, then there's only one direction it can go. So probably it's a good opportunity to visit us now. If you don't have the chance to visit us physically, you're always very welcome to visit us electronically. And there will be many opportunities. We're running again our online, massive open online course in implant dentistry. You can register and attend it through Coursera, a platform based on the United States. It's completely free. And the next round is going to start in September 2017. You're very welcome also to stay in contact with us through our Facebook page or attend some procedures if you're interested into our YouTube page. And now I think night has advanced already here in Hong Kong. Probably in some places to our west, we will have the night coming slowly, and maybe for the rest of you who are in Europe, you might be getting ready for your afternoon coffee. And I hope that we will remain in touch. I thank you all for attending this webinar. I thank also the IADS for the kind invitation and the opportunity to share these thoughts with you. And I would like to thank you and hope we stay in touch and meet again physically or electronically sometime soon. Thank you very much.
Thank you, Doctor. Now I'd like to give the opportunity for our viewers to ask. If you may wait a little bit, maybe someone will think about the question they want to pose. All the viewers are free to ask.
Take the presentation out, or how do I see the questions?
Sure. I will tell you the questions. Just a second.
Okay, good. Oh, I can see myself again.
Yeah, we can see you. Perfect.
Good.
Just a second. So everyone is free to ask. Thank you very much for your lecture, by the way. What time is it in Hong Kong already? I forgot.
Sorry, I can't hear you well.
What time is it in Hong Kong now?
Oh, now it's close to 11 o'clock.
11 o'clock.
Yes, it's 11 o'clock.
Okay. Any questions? I would have one question, if I can.
Yes, of course.
When
Thank
did
you can.
It's a little bit of a private question, but when did you decide that you wanted to focus on implantology?
Can you repeat that? I have really very bad sound. Maybe you can type it instead. Can you type it on the chat window?
Yes, I will. I wanted to ask, how and when did you decide to focus on implantology?
Oh, I see. Okay, thank you. The question was when and how I decided to focus on implants. Well, my initial training was in periodontology. So during my training in periodontology, I learned to place implants. But at that time, it was very limited to the surgical phase of the implant dentistry and not so much the prosthetic. Then I moved to Switzerland, and I moved to a department that was actually a fixed prosthodontics, so they were restoring implants. And then I realized how important it is to actually know about the restoration of the implant, the prosthodontic side of it, before you even conduct the surgery. And then I realized that implants offer a great opportunity to see the patient very comprehensively. Instead of just looking at the procedure, the specific placement of the implant or the augmentation or the surgical intervention, if you would have the overview, you could actually see the needs of the patient, discuss with the patient exactly what would address his needs best, and then place the whole implant dentistry component into a much wider plan. So I think dental implants give you the opportunity to see the bigger picture. And I think this is one of the most exciting things about it. They combine a lot of disciplines, they combine a lot of knowledge from behavioral science to periodontology, prosthodontics, surgery, uh, biological science, material sciences. So it is probably a very, very unique interface of all these different disciplines. And I think this is what has excited me about dental implants in particular. And it allows you to take many, many different directions in your research, in your growth and your own development as well.
Thank you for the very detailed answer. But I have one more question. What is harder or what is more difficult to learn? To place implants or to speak Chinese?
Ooh. Oh, God, I see.
You have a huge
Well,
respect for that, really.
yes. If you ask me individual, I can tell you I have placed many implants, but I only speak very few Chinese words. So it's easy. Thank you very much. Thank you for the opportunity. I wish you a good afternoon or good evening then. And we might meet again. Will you be attending the conference in Madrid?
Yes, we will, and I invite this way the participants of this webinar to participate also in IADS meeting, which will be held in Madrid in the end of August. And this way, I would like to thank you again for having accepted our invitation. We hope to see you soon, and hopefully you'll be able to bring us some other webinars in the future. Thank you very much again.
Thank you.